have a polling question, which you can answer on your app. Are disruptive technologies accelerating the pace at which policy changes are being enacted, yes or no? You can answer that question on your app. We'll have the results after our next panel is finished. So to start, I guess the question is for Dr. Dalton first. What do you see as the biggest impediment to improving broad health outcomes in cancer?
I think with the revolution that's actually occurring in what we know about patients, both phenotypically and genotypically, what's happening genetically and causing their disease. The greatest challenge, though, is taking that information, creating knowledge, and then presenting that knowledge at the point of care where the physician is trying to make a decision. So we have this abundance of information, but how do we harmonize it? How do we change it into knowledge that can then be used in decision-making by the physician at the point of care?
And what are the tools in your mind that you think would facilitate with that?
Tools, plural. I think it's going to be a multi-sector sort of effort. No one group, no one institution, no one entity can build the tools that we need. When we are attempting to do something like this in cancer called ORION, which stands for Oncology Research Information Exchange Network. And the idea is to build an ecosystem involving information, collection of data at the point of care, and then learning from it, and then presenting it back. So this will take, we feel there are at least 4 stakeholders. First, the patient, then researchers, clinicians, and administrators, including payers. So all 4 need to come together, coalesce, if you will, and create a value-added approach that each gains value by creating this ecosystem of information generation and ultimately knowledge.
Dr. Rhee, I'd love to ask you to put on your old public policy hat. As people might see from the program, Dr. Rhee was in public policy for a long time before coming to IBM. What do you see as the barriers to having cancer outcomes improve broadly, i.e. reducing disparities that we see in cancer outcomes within the population? What are the reasons for those disparities, and how do you think they might be closed?
Yeah, so I actually reflect on my time at HHS, at NIH, and we were focused on the National Institute of Minority Health and Health Disparities, and then some time as we looked at the Affordable Care Act, which in many ways addresses a lot of the disparities in some areas as it looks at Medicaid expansion. So, and I also reflect prior to that, my time in underserved communities in DC and Baltimore serving as a primary care physician. And in that setting where a lot of folks didn't have access, I think about the challenges that I faced and the team members and a lot of my colleagues who are still in that setting face in terms of disparities, whether it's with African Americans who have higher rates of breast and breast cancer and prostate cancer, or Asian Americans who have higher rates of liver cancer, or Native Americans, American Indians who have higher rates of kidney cancer, and Hispanics with cervical cancer. So oftentimes we put it in that framework. But then as a policymaker, we saw a lot of the challenges of translating what I would call science to practice. And typically that takes, on average, 17 years. And the role of policymakers is to, in my mind, play a role in shortening that distance.
And just to interrupt you for a minute, 17 years from when a treatment is available to when it's broadly deployed?
In general, at NIH, we'd reference, when we find a scientific discovery to delivery, where it would be in common practice. And that would be typically 17 years. Some people say 12 years, 13 years, it depends on the different areas. But that is a lot of time, and I think part of the challenge in this space is this idea of the different stakeholders, and whether it's scientists and researchers, whether it's policymakers, whether it's practitioners, whether it's innovators, like I would say at IBM, we're looking to innovate how we translate that data into an insight to that stakeholder at the point of care, so they can make and nudge them to make them aware of something that can make a better and faster treatment decision. So this idea of shrinking that 17 years to 17 seconds or 17 days or 17 months is something we all need to embrace and figure out our role in accelerating that knowledge and scaling real-world evidence-based practices.
Dr. Bishop, you come at this from a very different angle. When you think about sort of broad-based improvements in outcomes for patients, what are the impediments that you are most aware of or that you find to be most troubling?
I think we need better drugs There's no doubt that much of the cost of managing oncology is related to the side effects of the drugs we have today. And there are still too few drugs that are curative or really deliver substantial overall survival benefits. So we absolutely need better drugs. And I think the other major technology pillar is we need better diagnostics. The prognosis for cancer generally, this is somewhat of an oversimplification now with our better understanding of the immune system, but generally, the earlier the cancer's diagnosed, the better the outcomes. And there's lots of public health as well as technology issues associated with that.
In terms of how you would go about improving the speed at which the new drugs with fewer side effects are brought to market, the FDA has spent a lot of time trying to think of new pathways. There are all these names that people in the room, I'm sure, are familiar with breakthrough designations, et cetera. Do those go far enough in your opinion? Should the FDA be doing more? Is the FDA sort of discriminating against some classes of drugs in favor of others? How do you view the FDA's progress on this front?
I think they should be applauded. I mean, of course, many of us, I'm sure, including very dedicated people at FDA, would still like to see these timelines reduced further. But I think the effort that's being made to accelerate access to innovative medicines is really encouraging, and I think it's working. So I think we're on a much better path than we were, say, 5 years ago. I think breakthrough designation is the absolute example I'd point to. I think it's a really interesting idea that's going to see drugs getting approved more quickly.
Is there the need, there's this 21st Century Cures Act, which has been bouncing around Washington for a while, which includes broad changes with the FDA. Is that the kind of thing that you think would help? Is there anything worrying in that bill? It's controversial. I'm curious to hear the perspective of others on the panel as well, but perhaps we could start with you, Dr. Bishop.
Well, I also think it's very promising. I mean, it's just fantastic, for example, to see, significant increased funding for NIH in that 21st Century bill. So I think many of the themes in there, I think, are things to be encouraged by.
Do either of our other panelists have a view of it?
Yeah, I think the NIH and the 21st Century Cures Act are fundamental. If you look in the late 90s, when Congress came together to double the NIH budget, creativity just skyrocketed. That's when the sequencing of the human genome came together. You saw coalescence and collaboration for doing these major projects like sequencing the genome. Now, unfortunately, you look at it and where the purchasing power from what grants can be funded by the NIH has decreased 30% since that time. So the ability to actually to have the foundation that we grew used to in the late 90s, frankly, has disappeared. And what's happening with 1 out of 10 grants getting funded at best right now, we're losing an entire generation of scientists because these young scientists that are coming up are looking at this and going, is this what I'm going to do? They'll be postdocs till they're 45. That's just bad across the board. So I think things like the 21st century are absolutely imperative, and funding of the NIH to do so.
Of course, it also includes lots of other stuff in there, including changing arguably the standards around the criteria that would be involved in drug approval. Is that something that?
Yeah, I agree with Hans. I think the FDA has done a very admirable job with the fast track. It really started back in the AIDS epidemic, and you look at what therapies were being approved on fast track. It was anti-HIV. That's where it was almost an explosion of approved drugs. The FDA's got a challenge. They've got to protect us and make sure that these drugs are safe within the therapeutic index, but at the same time get these new drugs, promising drugs, to patients. That's a difficult tightrope to walk.
The regulations around, of course, the regulations have to evolve as the science evolves. So I'm thinking in particularly of cancer, of combination therapies and immunotherapy, and whether both the policies within the FDA, but also within academic institutions and within medical centers are keeping pace with the science, with the requirements around data sharing, for example, with combination therapies, how do you go about approving drugs that are two distinct drugs but might work in concert. So would any of our panelists be able to address that, whether institutionally within academia as well as within the FDA, whether there are certain types of cancer treatments that you see needing room for improvements in how institutions or the FDA consider them?
I mean, there are still real impediments to studying combinations. I'll just give you one very practical example. If you design a clinical trial that you hope to support approval and it includes a second drug, that drug has to be included in your label, quite understandably and quite appropriately. For it to be included in your label, there are all sorts of requirements about the information that you need to submit for that second drug, even if it's an approved drug. And doing that without the agreement of the manufacturer of that second drug is very, very difficult. So, you're almost setting up a system where, unless you can agree that cooperation early, it becomes a potential risk to approval downstream. So I do think there are still challenges we need to address to make the study of combinations something that will increase and becomes easier.
One thing I wanted to bring up is we're thinking about things at a macro level. I want to try to bring it at a bit of a micro level. So if you think about the basics of what a healthcare professional is doing as they try to treat a cancer patient and the challenges they have in terms of data, in terms of all this information in the medical record, all the information in the literature, all the information in these studies and trials and the journals that get published. And we know the average healthcare professional only reads 4 to 5 hours, 80% of them a month in terms of keeping up with the journals. There is a huge challenge there, which is going prior to policy. And it is about how do you empower those healthcare professionals at the point of care to be aware of opportunities of what the evidence says works, and also what the data says could work in terms of what we often reference as real-world evidence. What the data currently is telling you in terms of pathways of people like you and where there might be a treatment option available to you. So part of what I want to highlight is this, as we talk about technology, we have challenges there and we have an opportunity with the High-Tech Act and EMRs. The data is all in formats that can be read, and there's an opportunity to connect that data together and provide and empower that healthcare professional and also the patient to have a shared decision-making approach to look at the treatment options. And I personally think when you do it at that level, and then people start highlighting, well, the evidence says this works. Why isn't this getting covered? What's the issue with the payers and the policymakers? There's an opportunity from a grassroots level to bring attention to those opportunities to potentially get things covered. So I'm partly highlighting certain things that we've been able to experience and witness, and I've been able to see firsthand, which is the way in which a cognitive system like Watson can look at all the data, for example, in cancer, 300 medical journals, 200 medical textbooks, millions of pages of text in seconds to read that all, to look at the EMR, and to provide at the point of care knowledge of a clinical trial someone might be accessible to, knowledge to a genomic type of test or an FDA kind of approved drug or potentially something that's off-label. That information needs to be in the hand of practitioners at the point of care. And that, in some ways, as a policymaker, if I put on my policymaker hat, that will help me understand what policies we need to consider adapting. And ideally, it should be evidence-based from that grassroots level.
So how broadly deployed is that type of data sharing that you're doing with IBM, Watson, and cancer? And are there liability issues there? I mean, I know you're presenting the data to a doctor, but the Watson isn't making the decision, but how do you account for that?
So the way we like to call it, it's a trusted advisor that helps the oncologist make a decision. So that's the key piece. It's basically providing input and an insight that connects all those big data pieces at the point of care. So the oncologist makes the decision. So that's a key piece that we say. In terms of how widely deployed, this is also our philosophy, is the idea that you can put all this stuff on a cloud. You can have access to this type of knowledge. You're democratizing access to knowledge and scaling it and spreading it. So it's in places like India and China and Thailand and Korea we just announced. So there's an extraordinary opportunity, as we like to say, to potentially scale the expertise of a place like Memorial Sloan Kettering that trained Watson for oncology to places all over the world. So whether it's, I mean, you shouldn't be, based on where you live, limited in terms of access to the best advice and the best information and the best knowledge, and potentially access to knowledge of clinical trials and certain treatments. So this is what's very exciting about what we're doing, is we are looking to democratize access to that knowledge and those insights. And then to me, once you do that and people on the, in real world practice are seeing these challenges of saying that the evidence is not connecting to the reality of the policy, ideally you could potentially reduce those 17 years because those providers will start raising questions. Why isn't this being covered when the evidence says it should be?
Dr. Dalton, you do a lot of work in computing and how it might be applied here as well. Perhaps you could talk us through, in the research phase, how some of the computing power is being used and data sharing is being used to accelerate collaboration in a way that might speed the pace of innovation.
Yeah, I think you just said something very critical, which is accelerating collaboration. And again, the collaboration is with multiple sectors. Number one, with the patient first. There are efforts now ongoing where we ask a patient's permission to follow them throughout their lifetime. At Moffitt, we called it total cancer care. The idea was to ask the patient, will you donate all your data throughout your life? Will you donate tissue for us to study and do these molecular testing? And will you allow us to pool all this data into a data warehouse to learn from it? And by the way, will you allow us to recontact you if we find something? That's been going on for over 10 years. And this, with over 150,000 patients who have consented. And what began at one hospital and center 10 years ago is now at 14 and growing cancer centers throughout the nation, all using the same protocol, all using the same consent, standardized SOPs, standardized laboratory diagnostics, pooling the data. So you're going from a few thousands to hopefully millions and hopefully globally.
Billions.
Billions, absolutely. And patients want this done. They want to donate their data for you to share. And that's beginning. And what we need to go through this data by learning, we are learning the patient's course, and they vary. So obviously, even though the patient may have the same disease, the outcomes are very different. And we need to understand why that is. There's a term, it's pattern recognition with event prediction. That is, who looks alike? What are the outcomes? So what we need to do, and are beginning to do, is in pooling all this data is create communities, in silico communities, patients that look very similar. And are they responding to therapies in a similar way? And if not, why not? So then you start subdividing those communities and learning more. What we need to do is go from a reactive approach to medicine, which has been done historically, forever, to now a proactive, especially in cancer. We can't, when a patient has progressive disease, that's not the best time to start working them up for a clinical trial, doing all the diagnostics to be done. If you have gastric or pancreatic cancer and you have progressive disease, you have a couple of months to get things going. To do a thorough analysis of what might be best for that patient and begin that workup at that time is the wrong time. So what we need to do with the patient's permission is study them early, watch the evolution of their disease, and start creating options based on what we know about them now, so that when they do relapse and need a trial, you already know what the drivers are in that patient's disease and the options. You've already worked them up. So you go from a reactive to proactive. And by the way, by creating these queues, these communities, you're already saying, all right, which trials would this patient be eligible for now if they relapsed now? You've created queues for all these trials, which will shorten the time for clinical trials because you're not working them up individually. You already have populations who may be in need of a trial, and you've created options before they need them. So reactive to proactive, and the only way to do that is to pool this data, learn from this data by creating these in silico communities, and then create options for patients. And part of the consent is, will you allow us to recontact you if we find something that you might benefit from, such as a clinical trial? And of course they say, yes, I want you to do that. And so you have their permission. You have their permission to study them, learn from them, and give them back something if they need it. So again, the message is we need to go from reactive to proactive. It reduces the time to do the clinical trial, reduces the cost, and it gets the therapies to the patients faster.
And I'd like to underline that point that William's making about access to tissue. It's an enormous issue for accelerating our understanding about how to improve outcomes. We're all aware of the nomenclature of a stage 1, 2, 3, 4 tumor. Well, if you look at colorectal cancer, for example, actually how many T cells are in your tumor is a better prognostic indicator. So a stage 1 cancer colorectal patient with very few T cells in their tumor will die faster than a stage 4 cancer patient with lots of T cells in their tumor. But many of these understandings and their implication on drug development are hindered by the lack of tissue. And of course, fundamentally, there's a patient consent thing at the bottom of that pyramid, but often it doesn't happen because hospitals don't get paid for doing it and insurance won't cover it. So I think that point about delivering a deeper understanding of many of these diseases by their various stages of progression, including with tissue, is a huge issue for us.
So when you say hospitals don't get paid for it, is that a change that would need to come from the payer community? How do you incent the sharing and the availability of tissue as you just described?
Well, I think it's multifactorial. I mean, first of all, you have to have surgeons or radiologists and oncologists that are willing to ask the patient. There are certain risks associated with biopsies, of course. So there is a fundamental need for people to understand the benefit of doing it, again, based on individual patient consent. Yeah, and then it's economics.
I'm going to ask 2 more questions, but then open it up to the audience. One of the things that sort of is underlying, from my perspective at least, some of the comments that you've made is sort of how you take the promise of personalized medicine and deploy it on a broad scale, which has always been a question for me, sort of how patients with very individual, this mutation versus that mutation or at a different stage in progression of their disease, how you can treat broadly the population in a way that is efficient and make sure that people not just at Memorial Sloan Kettering or Dana-Farber, but throughout the country get very sophisticated care. And it sounds like your collaboration might go some of the way towards achieving that. But I wonder if any of the other panelists could talk about how you kind of democratize the most broad advances in personalized medicine and cancer.
Yeah, so I'd highlight, I love how you said reactive and proactive, and in many ways, one of the things you have to realize is, and then the value is a very key component. So we often at IBM talk about the 5 V's of big data, because that is the extraordinary opportunity. When I started practicing, everything was paper-based, even the journals, and it's all now in digitized formats, structured and unstructured formats that can be read. So what are the 5 V's of big data? It is the volume of data. Each of us as individuals will produce 300 million books worth of data in our lifetime. And it's related to the variety of that data. So we have to think of genomic data, which is a very key component of potential around personalized medicine. And there's a lot of opportunities in terms of policymakers to think creatively there. I do think one other group of policymakers we have to realize is especially in the US or actually across the globe, employers are in many ways purchasers of care and they're policymakers. In many ways, employers, like we at IBM, have made the decision to invest in things like vaccinations that we know prevent cancer, or cancer screenings like mammograms or pap smears or colorectal cancer screenings. And we've made our own policy as a self-insured employer to cover these, not only in the US, but in other parts of the globe. And there are ways in which the private sector can play an important role in advancing this variety of data that we know will play a big role in personalization. So the variety, the velocity of the data, we have to recognize that social, environmental, and behavioral factors play a big role in terms of, I would say, not only the evolution or the outcome of a cancer coming, but also the progression of cancer. So that velocity, I often like to say there's hundreds of health decisions we make every day that impact our health. How do we start to think about that data? It's the veracity of the data is also very important, and ultimately the value of that data. And what we've discovered in many ways is that people are willing, like I share with my app, Waze, I'm willing to share where I am if I'm going to get feedback about, where there might be a cop or where there, how I should be, might get to a certain place. And I think in this current mobile type of world, we're willing to share some aspects of our data to get value back. And that's a very key piece, to get the value back. And it leads ultimately to the ability to what I like to say is, we like to say is predict. That's a very important opportunity around big data. personalize and this promise of personalization. For example, I'll give you a simple story. I was just in Tokyo a few weeks ago. We met with the researchers there at University of Tokyo. They have this offering related to genomics that Watson has able to look at all the literature as it relates to genetic mutations. And actually, there was a case where a patient there, and actually if you look online, you can find it, NHK covered it. There was a woman with AML who actually, as a result of the oncologist sharing it with the researcher, her genetic mutations, they actually found that there is a possibility that she might have a different diagnosis, looking at the literature based on her genetic mutations. And as a result, the tumor board and also the oncologist decided that there was a different diagnosis that they had to come to, and as a result, changed their treatment. That's an example of big data playing a big role in an insight that is helping to, frankly, save a life. And so there's opportunities where we can personalize, that's an example of it, prevent a bad outcome, and also promote health. And as we think about health, I think we have to think very holistically about not only cancer treatment, cancer prevention, cancer detection, and also the holistic view of health, connecting all these big data pieces together.
So this is to follow up on a question that I asked about regulatory approval in oncology for the FDA and whether it could lead to more efficient and less costly drug development. And so I think that's probably best posed to you, Dr. Bishop.
I think perhaps one of the most encouraging themes are these so-called adaptive designs, where your drug development strategy can actually follow the emerging data in a trial. All of the same hurdles still need to apply in terms of showing benefit and quantifying benefit to risk. But I think adaptive designs can play an important role of accelerating learning and even approvals.
And to just to clarify for the questioner and for me, how far along the advent of these adaptive designs are broadly deployed within all areas of oncology in the FDA?
It's early, but I think FDA are open to them. So I think we'll need to continue to encourage it and see how they develop.
Dennis Morgan, medical oncologist. So, big data is dazzling in terms of signal detection and decision support. What about what I might call little data, which is, for example, in the office where still all too often we're relying on fax machines and secretaries fighting with the hospital about HIPAA compliance to get information about our patient from last night. To capsulize my concern, do you think that EHR vendors should be able to trap data with proprietary formats?
With regard to?
With trap data in the EHR with proprietary formats.
Track data in the term of what type of data are you? Yes, I think data definitely needs to be tracked so you know where it is, mapped, in other words.
No, not track, trap.
Oh, trapped.
Trap, yes. Look, doctors hate EHRs.
Yes.
And the railroads solved the problem of standardizing the gauge so the industry could flourish. We haven't solved the problem of a standard interoperability of EHRs. It's a big problem.
Absolutely. As you might imagine, with this alliance of cancer centers, they're all using different EMRs. And yet we are extracting data from every patient that enrolls into this effort, this total cancer care effort, from each institution. And that data has to be harmonized. Otherwise, we can't compare data from one institution to another because of the differences in EMRs. So what we've had to do is create basically a common data dictionary defining common data elements, which takes a great deal of work on each patient, and then aggregate that data. Knowing where the data is one thing. Knowing what data definitions are another. I think Hans and Key both said it. The meaningful use, which was part of the ERA Act and the High-Tech Act. Step one, it's in 3 stages. The first stage was data collection and sharing. That was
clarify,
started.
These are the meaningful use regulations that were brought forward
via
the
High-Tech.
Obama administration
Yes,
through
through
High-Tech,
the American
and the requirements that hospitals would have to apply. I'm just
precisely.
in case people aren't aware.
That's right. Well, it created more work without much value, to be honest. Just my opinion. Because the problem, we're still in the step one. It's a three-stage, and by the way, the meaningful use is concluded in 2016. It's a 5-year effort. Step one was data collection and sharing. We're still in data collection and sharing. It still remains a huge challenge because of the lack of harmonization of data that's being generated.
Our next question is on the incorporation of big data in healthcare. The natural question being, you would think that this would be incentivized already by the current system, but are there obstacles, systemic barriers that might impede the adoption of big data in being integrated into cancer care and cancer research? Does anyone?
I haven't met an institution yet that wasn't enthusiastic about the potential. It's the cost and what you do next and some of the regulatory issues such as HIPAA. What can we share, what can't we share? Even when a patient consents, there is a great deal of angst about what data you can actually share between institutions, and this is to learn. That's the intent, and the patients consented and said, I want you to study me. And we say in the consent, we're going to share your data. Even that, there remain barriers.
But it's institutional barriers, not legal barriers.
Well, I think they can be interpreted. The institutional is citing the legal.
So I'm going to connect the dots here. A lot of issues as it relates to data and I would say the topic of trust. I mean, the challenge in many ways, especially in healthcare is fundamentally about relationships, I like to say, and technology is meant to facilitate and improve and augment those relationships. And in many ways, we only share data with people we trust. And ultimately, that big data, if it gets connected and it gets intelligent, then there's an opportunity, if there's a valuable insight, then people will start to trust the sharing of that data. And that is part of the challenge we have with EMRs and the challenges that a lot of times, I had a tough time with these EMRs that I was implementing and putting amongst the providers I was managing out in DC and Baltimore. So we need to now move to the next stage of making it really meaningful and insightful at the point of care. And so I think it's like many innovation curves. I mean, we're seeing this across the globe with IBM and through the power of making that data intelligent. You got early adopters, you got innovators, and you've got a significant group that's really excited about the opportunities in big data. And I believe things are going to continue to progress and evolve, and there's going to be some extraordinary value that comes about as a result of our partnered work together. The key is, though, you have to seek, I'm going to use another Stephen Covey reference, the speed of trust is one. You have to seek to understand to be understood. So whether it's scientists, policymakers, practitioners, we've all got to work together. We often like to reference there's patients, there's providers, there's payers, there's policymakers, there's product manufacturers, there's pioneers, there's purchasers. There's so many stakeholders in the healthcare system who often have one view of the healthcare system. And somehow we need to get together, be at the table, and figure it out together. And that is part of the challenge, because people are a bit nervous as things transform about what piece of the pie they might lose or gain. And ultimately, we've got to all gain towards improved population health.
So I think we'll leave it there. That was a very interesting session. Thank you so much. I'm sure people will want to continue to pose questions to you during our coffee break, which is coming right up. But we're going to release the results of these poll questions through the app, which I think should come up on the screen shortly. What disruptors are they accelerating? No. That's pretty interesting, actually. That disruptive technologies aren't accelerating, that there's a lot of skepticism in the audience. I heard a lot of optimism, actually, on stage. What do you have a response to that? Do you think that that's surprising, that results?
Well, until it happens, you have to prove we can do it. I think that's a healthy skepticism.
Yeah, I think, and from my own experience being in the public sector and now in the private sector, I think sometimes when we think about policy, we think public sector. We ultimately need to find ways to integrate. And I do think, I recall, at HHS, part of the perception was, we were slow and we weren't as fast as the innovation. And frankly, I had a lot of great colleagues at FDA and other federal agencies who were, in my opinion, innovating at an extremely rapid pace and trying to adapt. You're talking about being adaptive. So I think sometimes this is a lot about that integration of public and private partnerships and frankly, the Cancer Moonshot is a great demonstration of that in ways in which we need to make more of this yes.
Okay, so I think that's a good way to end, that there's lots of possibility here, but it really, the proof will be in the pudding, of course, for whether we can actually make good on all the promises in the programs that are just starting to take off. So thank you so much.